The ongoing COVID-19 pandemic has disrupted many of our routines, including the way we engage with our healthcare providers. According to a national survey commissioned by the Canadian Medical Association, Canadians who connected with their doctor virtually during the pandemic reported a 91% satisfaction rate, which was 17% higher than in-person emergency room visits. This raises more questions than answers, as access to broadband high-speed internet connection and mobile devices remain a barrier for many populations. In this episode, we'll be speaking with a special guest about how telemedicine and other virtual care technologies can be leveraged to provide healthcare access to hard-to-reach populations in a way that does not exacerbate existing health inequities.
This is the Public Health Insight Podcast.
Hello, everyone. My name is Gordon, and welcome to the Public Health Insight Community Conversation Podcast series, and I'm joined with my fellow co-host, LaShawn.
Before we move on, it is important to note that the views expressed in this podcast are our own and do not represent any of the organizations we work for or are affiliated with.
Our guest is a primary care physician based in London, Ontario. He is the Chief Medical Officer for iTelemed Canada Telemedicine Group and is an adjunct community faculty member for the Department of Family Medicine at Western University. He is also a working group lead for the IEEE Standards Association Telehealth IC Virtual Care Lexicon as part of a team to recommend standards to increase the accessibility of digital health for remote and rural low-resource regions. He is early into exploring the work within WHO private sector collaboration and innovation for digital health. He has a deep network within stakeholders in the private and public sector and enjoys sharing his knowledge, facilitating connections, and encouraging others willing to tackle issues of health inequity in Canada and the rest of the world. Please join me in welcoming to the Public Health Insight Podcast, Dr. Keith Thompson.
Welcome, Dr. Thompson.
Thanks so much, Gordon, LaShawn. Really excited to be here with you today. And, as I said before we started, this has been a journey for me, right? I'm a late comer to virtual care, and I jokingly say further along in life, I think, than maybe some of the guests and yourself. So I don't have a lot of time left in life. So, if I'm going to learn as much as I can, let's learn fast. And certainly excited to be here. Really appreciate the opportunity to talk about virtual care and its implications, right, to general population use, but also marginalized populations. And kudos to you guys and Public Health Insight. Some amazing work. I had banged into Gordon through a pitch event for social innovation around opiates, and learned of the work you're doing through that, and really quite awesome, and really inspired by the network that you're creating. And so thanks for this opportunity.
So Dr. Thompson, tell us more about what you do and the organization that you represent.
Yeah, so I'm a family care physician, family practice here in London, Ontario. Solo practice right now, but fee for service, and we can talk about physician reimbursement maybe on another podcast. But really, my journey has been into virtual care and its applications into primary care, and really staying centered within that which is publicly funded. And through that journey, discovering that, there's some issues, obviously, in terms of equity, and we've seen a greater disparity, certainly during COVID. Along that journey, you learn of other people and organizations working in this area. So I'm adjunct faculty at Western, doing some co-investigator work under Dr. Bridget Ryan and several of the family docs within the Faculty Department of Family Medicine, researching what is best practice and what will the guidelines be for virtual care, because pre-COVID, we didn't really know. We were slammed with this great pandemic, and we were in survival mode. And certainly most of the encounters we do are by telephone because we have the relationship and we know the patients, and that's probably easiest for workflow and probably easiest for patients in some ways. But my other affiliations, the IEEE Telehealth Industry Connections is what the IC stands for. And that organization formed recently. As you know, IEEE creates those standards around electronics and information communication technologies. What's the basic standards so that your toaster doesn't shock you when you turn it on. But they realized it in terms of telehealth, in terms of virtual care. They really hadn't turned their lens onto that area. So this whole organization, which is open to any members, by the way, so I'd encourage anyone listening that has thought about wanting to offer their expertise. It's a volunteer, it's sweat equity, but really important work that they decided to focus on. And how do we create a infrastructure and ecosystem that's going to allow access regardless of regions, and how do we improve connectivity, and what are the security and privacy issues that we need to keep in mind, because we may be able to get easy connectivity into a community, but is it going to be equitable in terms of privacy and in terms of security? So that has to be considered. So that's where IEEE is in. The World Health Organization, again, is a kind of a new gig for me. It was merely a roundtable discussion that I was invited to, and was able to participate, still ongoing, but a fabulous network. Met some innovators doing some work in Africa and remote regions in Africa and Kenya. We can talk about that as well, but certainly really great examples, right, of how to do a lot with little. So that's kind of the background of my organizational participation. Locally here at home, bringing it to that Ontario perspective. As you know, we're moving towards Ontario health teams, and it is getting us to think as primary care beyond the person in my office in front of me, but as a collaborative, our whole population. So not just the one diabetic that I'm meeting on a virtual visit or telephone or office face-to-face visit, but all 200 patients in my practice who are diabetic. And likewise, as a region, those thousands of patients who are diabetic. And there comes a challenge, I think, in equity and access, because within London, the estimates I'm hearing, I'll say Western Ontario Health Region, we have up to 70,000 patients without primary care access. And if you scratch down a little bit into that, and what are those limitations of access, and what is creating marginalization that's preventing access. It may be geographic, it may be those social determinants. And that's my last comment, and I really appreciate being here, is as I started to scratch deeper into this, realizing that digital divide really equates with the social determinants of health. So many of the things that are creating poor health really are also similar to what is preventing access to our digital health ecosystem, or virtual care as we call it.
Yeah, no, fantastic. Thank you for sharing that. And I was wondering if you could share a bit more about iTelemed Canada from a more of an operational perspective and your role as the Chief Medical Officer.
Yeah, absolutely. So iTelemed was formed as a non-for-profit, and financial conflict of interest declared. I'm a chief medical officer, would declare revenues if I had any. It has been sweat equity to this point, really deeming to stay within the publicly funded guidelines, which pre-COVID, OTN was pretty much the only way to access virtual care for patients that was funded. So you had to be a physician registered with OTN, Ontario Telemedicine Networks, one of the largest virtual care telemedicine networks in the world, actually. So some phenomenal work that they have done, but it's clunky, it's a hard workflow, it doesn't easily adapt. And so that really, outside of OTN, were these private systems, right? You had Maple, Dialogue, Akira, all these companies springing up, providing virtual care, telemedicine care, video chat encounters that wasn't funded. So it was a direct to consumer or through employer-based program, whereas OTN was publicly funded. So iTelemed has really been looking to stay publicly funded and leverage in the system what is open to all of our patients in Ontario, right? Not just those that have ability to pay. COVID has changed this a little bit, so we're seeing now that under the Ontario Health guidelines, we have, I think last count, 5 or 6 vendors, Maple, DoxyMe, several of them that have applied for verification, which what that means is when we reach a point that the Ministry of Health may pull the plug on these temporary fee codes to encounter our patients by video or telephone, these other vendors will likely be able to say, we're approved, we meet the requirements, and so any physicians who use our platform will be allowed to bill for that service. Whether that will address the issues of equity of access, would be a whole other discussion, but that's really how we differ perhaps somewhat in iTelemed versus, the other systems that are out there. So we're doing some work with Participation House here in London, and those are very high needs individuals, wheelchair bound, congregate living. To bring them to the office is, an endeavor unto itself. $200 to $300 actually in costs for attendant care and getting them to the office. Wow. Or a physician would have to take time at the end of his day, which is usually after hours, and the premiums and fee codes to do that can be in excess of $120, $140. We can do that visit virtually in many cases for $45 or less dollars. And we're still on an uphill battle, just so you know, to get the allowance for the virtual house call fee code. We're allowed every other fee code virtually, but we've really been fighting to try and say, guys, this is really an issue of access for highly complex patients. Can you allow those encounters to happen? Which in our case, we're using a stethoscope and the equipment to examine. So it's not just a video encounter. We're going deeper into that encounter with the patient, as close as you could get to a bedside exam. And that's still, as I said, still a challenge to find funding for that type of program.
Right. And that segues us perfectly into the next thing we wanted to talk about. So you've been practicing as a primary care physician for a number of years now, and we know that telemedicine has emerged as a tool to help providers provide healthcare services to their patients. And it's superimposed onto COVID, of course, because people are less able to move around and with the lockdowns and the restrictions and closures. So before we get into it, we're hoping for you to share with us, clear up some terms for us. I'm not sure if they're interchangeable. We've come across terms like digital health, telehealth, telemedicine, virtual care. So we're just wondering if you could situate us a little bit.
Yeah, for sure. And I think we're fortunate in Canada because there's a great working group under Digital Health Canada, actually, that created a lexicon that was really meant to try and define some of these terms. And why is that important? First off, let me say that as we develop standards around this, and that's the working group within IEEE, as we're looking to license and create standards, creating standards around terms is a challenge. And honestly, no one's been able to do this. There's been a lot of talk and wrestling with it, but we often kind of get mired down in the clinical applications, whereas those that are in the technical side of it are looking at this as an industrial or information communication tech standards. So merging those two worlds has been a challenge. Certainly in Canada, what's been done is we talk about virtual care, and that, think of it as the umbrella or all-encompassing term for all things digital health, the platforms that are used. When you go down into the clinical encounters, we can speak of concepts or domains was a terminology that was used here in Canada. And the concepts or domains would be the ways in which you engage with the patient, the general terms. So telehealth, telemedicine, e-health, consumer health, telemonitoring, telepathology, telepsychiatry. Just by those terms alone, you can kind of feel, you get an implication of what's going on. Oh, teleradiology, absolutely, looking at x-ray, ultrasound. Telehealth, telemedicine. So telemedicine traditionally implies a term where a physician or allied health professional is engaging with a patient and treating them remotely. So again, virtual care, just to clarify, is other than face-to-face. And telehealth might be all other aspects of that. It may be an email, a text, it may be an exchange of information between provider to provider, provider to patient, between sources of information on the patient, would be all within that domain. We get into capabilities, and then that is the more specifics of the tools that you would use. So the execution of it can be synchronous, like we're talking right now live, okay, or it could be asynchronous. I could record my symptoms and findings. I'm a nurse provider getting the parameters on a patient and upload it, and the physician comes in later and encounters, or the patient uploads their blood pressure or their blood sugar and throws it into my email or my inbox as a digital in, and I look at that later. But the capabilities would be, again, telephone, messaging, texting, peripherals, was one that I was able to kind of play. Hey guys, you got to include doing an exam, right? The equipment to look and provide that gets included. Patient education or e-consults, right? So I'm creating a parameter and sending it to a specialist. So virtual health concepts or domains of platforms you're interacting on and the capabilities. That's the way Digital Health Canada defined it, and that's a pretty good generic, and I think it's got potential, and we're bringing that forward to IEEE, and they were inspired by this. What we need a little bit more definition around is the population health aspects of that, right? And that really hasn't been addressed because there's a lot of stuff we're today talking public health. You guys are the heroes during the pandemic, right? And so population, big data, regional data, right? And what does that look like? And that's still within a domain, if you think of it as virtual care, but the capabilities may be different. Maybe it's going to be an AI analysis of data and say, look, our STI rates in this region are very high, we need to address that. Or our TB rates, right? So it may be regional. So that's how I think we think the definition, virtual, break it down, the platform we interact, and that may be digital, e-health, m-health. I would tend to just group those all into one. And then the actual means of engaging with those patients are more kind of the clinical specifics.
Right, cool. Yeah, like speaking of the like specific populations or just populations in general, there was a survey done in 27 countries that really found that 1 in 10 respondents had tried telemedicine before, and 4 in 10 indicated that they would try it if it was available. So under normal circumstances before the pandemic, what was the uptake of virtual healthcare in Canada? And in your experience, have more patients been using it as an option during the COVID-19 pandemic?
Yeah, so again, pre-COVID, I think the uptake, that there was trajectory we were gaining, but it was still probably very small. And I don't have the exact stats in front of me, but I'm guessing it was probably less than 5% thereabouts, and COVID was just a great accelerator. It was literally, if you look, it's like the switch went on, right? And boom, it was zero face-to-face or very near zero, and everything was virtual. Virtual being telephone, email, or video chat. Video is a small percentage. Even still, if you look at the work being done in primary care, we have the advantage of knowing our patients longitudinally. And so that's why a platform like telephone or text messaging, even for that matter, works well because we have the history on the patient. We've got years of encounters and information on that person. If it was a new encounter, I would hazard to say it's maybe not going to work as well, and there's some risks associated with that episodic encounter using virtual, right? So I think if you look at the CMA did a study and where we're going to go during or post-COVID, it's about a 60-40 split, meaning if you had a new problem and you had to encounter your physician, how would you prefer to do it? And it's roughly 60% are saying face-to-face, and 40% would be okay with a virtual encounter. So that's interesting, right? There's still that therapeutic need or desire for that face-to-face. There may be just something there that's satisfying or gratifying to the patient that maybe we need to understand what we can and cannot do in that regards for virtual.
Specifically for your practice, for example, did you use a lot of telemedicine pre-COVID? And now that you shifted more, I'm assuming, to more telemedicine, what are some of those nuances that you figured out or had to work through with this kind of influx of people using this?
So again, probably a disparity between those of us fee for service and those of us that are in capitated models. So just to define that, that means in Ontario, I'm paid per visit. I'm paid per patient. There's good and there's bad about that, and we can leave that for another day. Capitated model, here's your population, X dollars per head. Whether you see them once or 20 times, doesn't matter. So workflow is extremely important in those of us in the fee for service. And I was definitely starting to explore using OTN. In fact, it was November of 2019 that OTN said, okay, for those physicians registered, you can send a link to the patient, they open it up and you can video chat and you can bill OHIP for that process. So that was a first, because prior to that, we had to engage patients only if they were at a recognized OTN endpoint, which was typically a hospital or clinic. There was some private providers out there doing it, but pretty much that's the only way. So it was working. The patients loved it. It was convenient, but it was clunky because you had to send the link. The patients often didn't understand. They would call my front desk, who became my tier 1 tech support. How do I load it in again? I can't get it, right? So when COVID hit, certainly telephone became the lifesaver when they released those fee codes. And I have to say, the patients, most of my feedback, and this is anecdotal, there's no maybe firm data on this, but I think the surveys would support that patients like telephone. I mean, as soon as they connect, bang, we're there, right? There's no loss of time to figure out the video, or is the sound working, is the connectivity good, et cetera, et cetera. For telephone, most people work. When we get into the marginalized populations, that's interesting as well, because there are some folks that video and Wi-Fi is not an option. I mean, they only have telephone. Right. So, virtual care adopts very well to that. So I think still we're seeing about 80%, from what I understand, would be telephone, and maybe the other 20, a mix of email and video chat.
Interesting.
Or text messaging and video chat, yeah.
Interesting. That makes me curious about, you talked about the logistics of telemedicine, fee for service versus capitation. And I wanted to hear from you then. Telemedicine is meant to expand the geographical boundaries, if you will, through which medicine or healthcare can be delivered. So are there any barriers in terms of where a physician is registered in one province, and what are the limitations to serving people in other jurisdictions or other provinces?
No, definitely there are, right? So as an Ontario licensed physician, I'm limited to engaging my patients within the province of Ontario. Now, if they are residents of Ontario and they're outside of the province and they're my patient, I can still engage with them virtually. But to go outside of that is a concern. And one company that's done very well in this regard, certainly Maple, was able to grow and scale their physician pool. So if you think of it, that they were able to get physicians registered across many provinces. So to cover the late or evening hours in Ontario means recruiting physicians able to visit from, say, BC, or vice versa into the eastern provinces. So that was really, I think, a sweet deal, right, in getting that cross or provincial coverage. But for me, as an N of 1, it's just not practical to really go and apply to multiple provinces, because I'm just not going to get those, many of those encounters.
We know that there's a lot of push for physicians to service these underserved communities in rural regions. So given the fact that I, as a physician, have this option rather than moving there in person, is there a danger then that eventually there'd be less physicians and healthcare providers in those regions available for in-person interactions?
Yeah, that's a very good question. And I think in COVID, we've seen in the northern communities, physicians adopt virtual care the same as within the southern regions because of that risk of face-to-face contact. Prior to COVID, the question is, or has been, and certainly OTN has done some work in this, is how do you bring those encounters, how do you bring those services into the northern, in Ontario, for example, northern regions, underserviced or Indigenous communities? How do you bring those services in other than face-to-face, and can virtual be a supplement to that care when the physician is not there? So it's complex because as I hinted at earlier, that longitudinal relationship is most important. And depending on which, population we're dealing with, if it's Indigenous, for example, it's extremely important to have and build trust. And one of the challenges has been physicians tend to serve in northern communities because it's mandated by, their undergraduate training, or maybe they've done international medical graduates. They've come in and done extra training here, or had stipends. I think there was a program to promote physicians setting up in northern Ontario regions. And as soon as that 2, 3, 5 year requirement is met, bang, they're gone, right? And so it really does leave those communities in a constant sort of turnover rate. If the telemedicine services allow for greater support to that primary care, which is really what OTN, I think, was built upon, bringing the specialists into those communities and help prop up primary care when there was uncertainty around diagnoses or treatment, then it can be a value add to retain physicians that don't feel like they're working totally alone. They have that expertise to draw upon. And I think really that's where this type of technology may be a win-win. How it's, or will it, be enough of a value add to attract physicians to serve in those regions, I think still needs to be discovered. You would say the potential is there. Can I be a physician in Southern Ontario and have my patients, and I'm the MRP, which means most responsible physician, can I be the MRP for somebody that I may only see face-to-face once a year when I fly to that community to come in and establish, right? And I think there are some regions where they say if you provide that care remotely, it's required that you X number of times per year, per month, provide face-to-face as well. And I think that's wise, because really it can't all be done by virtual care, telemedicine, or remote care. You've got to have some face-to-face encounter.
Yeah, no, totally agree with that point about you have to have that face-to-face encounter. And it seems that based on the results that you presented earlier, 60% do prefer having that face-to-face contact as well. I found some other survey results from Abacus Data Poll, and it was commissioned by the Canadian Medical Association, like you alluded to earlier. It showed the 91% satisfaction rate when working with or interacting with virtual care. Other kind of interesting tidbits were 46% preferred virtual as their first point of contact, and 45% of people saw this to improve their access to specialists. And with that, like you already mentioned, 41% also think that this can improve the timeliness of healthcare services. But just in general, what are some of the benefits of telemedicine? Like, we hear about things like teletriage to assess and decrease the volume of in-person visits. We talk about the potential for mental health services and stigma that may be a barrier in person. Is there concrete evidence that this does improve patient care? And you kind of alluded to costs earlier. Does this actually limit or control costs?
And that's a great question. And I think, honestly, those studies are ongoing. I know of one, at least here at Western, that's looking at utilization. And as we have the virtual emergency rooms set up across the province, that's a recent funding. Using virtual encounters for those patients that maybe are lower acuity and don't need to come to the emergency room as a face-to-face. So I think that is still being clarified. The benefit is, you would hope, the benefit for patients, ease of access, certainly, right? Not having to take time off work, drive to the office, get a script, go to the pharmacy. All of those parts of the encounter can be virtualized or, just electronic transfers. The downside is there's going to be some visits that require a face-to-face, and some of that may be patient determined. I think in one other interview I referred to work by Ian McWhinney, what drives patients coming to the physician, and it's that limit of tolerance. They just can't stand the pain anymore, or the itch, or whatever. The limit of anxiety. They're just so worried. Oh my gosh, I think it's cancer. I'm really concerned. The ticket in, they want to come for a new script, but have a doorknob comment. Oh, can I talk to you, doc, about my alcohol use, or whatever. And administrative duties. They need a note. They need a clarification on something. So thinking of that as the primary driver, which of those parts of the encounter can be met virtually? And I think for mental health, for sure, we can probably achieve satisfaction with that. And I think that there may be studies that would support that. I can't quote them off the top of my head without doing a little bit of digging on it. Utilization is a huge concern, and I think that is still being looked at. And the reasons are, pre-COVID, I'll give you an example. A patient goes to a virtual health center and they're encountered. The physician assistant registers them, does a bit of an exam, looks in their ears, takes a history, dials up the physician. The physician comes on for literally a 1 or 2 minute encounter, says, oh, it looks like you have, according to the nurse, a middle ear infection. I'm going to give you a prescription, and off they go. So I've experienced firsthand some patients have come away not feeling satisfied. Obviously, whether it's the anxiety or limited tolerance just wasn't met. So the next day, they're in my office seeing me because, I don't know, doc, like it was a video encounter and not sure. They didn't listen to my lungs, right? So there's a double dip, right? That 2 times, first filling virtual, and we ended up with another face-to-face. And I know all of the early studies that were done in Wellington, Waterloo, that enhanced access to primary care. One of the concerns in the rural regions was the primary care docs working in Emerge, working in the hospital, dial up, have the encounter with a patient, it's a video or it's a telephone. Oh, I'm here at the Emerge, come on down, right? So it kind of uptick to a face-to-face, and is it needed? And I don't want to criticize my colleagues and not knowing all, but you can see those would be examples where you could optimize the billings, right, around virtual care. Similar to, methadone. I always pick on those guys, but physician services, huge, $1 million, right, for providing methadone. It's a needed service. Don't get me wrong, I understand that. But if I'm a patient with COPD or diabetes, and I come and I get my methadone, and I want to talk about my chest, my cough, oh, sorry, not my problem. You got to go see. Well, I don't have primary care. You're it, right? So that $1 million+ and if you look at the data, it's. I know they even dropped the fees, right, to try and kind of throttle down some of this utilization. The danger is, will virtual care be used that way? Is there potential really to optimize billings, and it becomes a ka-ching for the docs, but not providing a value or service? And that gets into the whole arguments around reimbursement, right? And individual services versus thinking as a collaborative, and where you in public health are looking at a whole region. You've got the sky view. You know where we're hemorrhaging, right? And where services are being utilized. And now, how do you engage with primary care or hospitals or providers in the community to do a better job to focus in on that? And so thinking along that lines, that's really where I think virtual care has to aim, I think, right. And I don't know that we're there yet, but I think that's hopefully where we'll go.
You have just heard part 1 of Gordon and LaShawn's conversation with Dr. Keith Thompson, Chief Medical Officer of iTelemed Canada, about what telehealth is, the various ways in which it can be delivered to serve patients, and how the pandemic has influenced the availability and uptake of telemedicine services. Join us in the next episode as Dr. Thompson shares his thoughts on the digital determinants of health and how telehealth can be leveraged to reach marginalized and isolated populations. Thank you for listening to the Public Health Insight Podcast, your go-to space for informative conversations, inspiring community action. If you enjoy our content and would like to stay up to date, follow us on Instagram, Facebook, Twitter, and LinkedIn. To learn more about our community initiatives and how you can support us, visit our website at thepublichealthinsight.com. Join the PHI community, and let's make public health viral.